The Senior Rehab Podcast is sponsored by Health IQ. Health IQ is a special rate life insurance company for health-conscious people like you and me. If you're in the market for life insurance to have peace of mind and to protect your family, I'd highly recommend checking out this company. They are the only life insurance company to use data to leverage lower life insurance rates for active individuals. So the result is that 56% of Health IQ customers save between 4 to 33% on their life insurance premiums, which can definitely add up to big savings over time. To find out more information, just go to healthiq.com/SRP to support the show and to get your free quote. Hit me.
This is a Senior Rehab Podcast, the podcast for rehab clinicians that want to better serve older adults.
Hello, friends. Welcome to the Senior Rehab Podcast. Thank you for spending your day with me and Jackie Osborne. She is a guest today. She is a physical therapist and the director of the Residency that our good friend Joe Daniels is at right now, the Brooks Rehabilitation Institute. Jackie's a PT and she loves what she does. She's blessed to be in a position where she can facilitate and promote working for older adults. She's a recently recertified GCS. She initially got that certification in 2007. She earned her CEEAA in 2012, and she's a coordinator of that geriatric residency program in Jacksonville, Florida, which she developed in 2010. Since that time, they've achieved reaccreditation for another 10 years. She's very, very proud of her graduates and hoping to work with many more. She's also involved in different and exciting ways with the FPTA, the APTA, and the ABPTRFE. She also teaches the entry-level geriatrics course to the third-year DPT students at the University of North Florida. Jackie, welcome to the Senior Rehab Podcast.
Thank you so much for having me, Dustin.
No problem. So we're going to start off. Do you have any embarrassing Joe Daniels stories yet?
No, more of an embarrassing thing that I did in front of him and his patient that he brings up a lot. And so I think I'm confident enough in my abilities that I can share this.
Mm-hmm.
So we had a patient, and he just finished giving me, basically the ICF model framework of this patient and what are the contextual factors, one of which was that she has macular degeneration. So a few minutes later, I'm making small talk with her, and I asked her if she liked to read or watch TV. And she said, well, no, I can't see, and I felt terrible. And, so we laugh about it. And I apologized to her, of course. And she had a good attitude about it. But it did stimulate a deeper conversation about how she could spend her time, given that she was not able to read or watch TV. So,
he called you out,
Joe
man.
Kick out of that.
That's funny. Joe, Joe did the shorts segment of this podcast and did an awesome job with it right before, he started there with you. So let's dive into kind of, I guess, your career up to this point. I mean, it's pretty impressive, just kind of the path you've been on, but kind of give us a quick and dirty of your PT career up to now.
Okay. Well, I graduated from, then it was called Beaver College in Glenside, Pennsylvania. In 2003, it's called Arcadia University now.
Where in Pennsylvania is that?
So Glenside is a northeast suburb of Philly.
Okay.
It's right over, it's over the Talconi-Palmyra Bridge, which is very close to where my grandparents were from in New Jersey. So sometimes people from that area of New Jersey just say they're from Philadelphia because it's so close.
Right.
But so that was the area where my parents grew up, and I kind of came back into that area in a roundabout way. I went to the University of Delaware for my undergraduate studies, and then ended up in Philadelphia, which I absolutely loved my program. I felt like it was the right choice for me. It was wonderful. So, so after I graduated, in between when I entered into that program and when my family, my parents, actually, they moved to Florida. They retired. And I guess not exactly retired. I think my father was still working then. But in the middle of my school, they said, hey, why don't you, when you're finished, why don't you come to Florida? And I had no intentions of doing that. I had established myself. My extended family was still in Philadelphia and New Jersey area, and I didn't intend on it. A couple days before graduation, my mom said, listen, you've got to go online. There's a position open at the University of South Florida. So fast forward, I applied and ultimately worked at the University of South Florida until 2009.
In academia or in a clinical capacity?
Well, it kind of evolved. I started out in a clinic 100% of the time as an outpatient university-based clinic. And my position moved to, I don't really remember exactly the percentage, but I would say probably 40% of the time I was in the classroom and the rest of the time I was in patient care. And so I happened to be there during a time when they transitioned their program from a master's program to a DPT. So I had the kind of experience of being there during that transition, which was, kind of an interesting learning experience. And yeah, so then I had my son in 2009 and ended up going on maternity leave. And then learning during that time that my husband had been recruited to Brooks as he had been doing the orthopedic residency and manual therapy fellowship at Brooks.
So he's a PT as well.
He is.
Yeah.
Yeah. So long story short, he said, yes, we'll go as long as, my wife can come and do something too. And that's when Bob Rowe, who I'm sure you might be familiar with, who is my boss, he's also APTA Board of Directors member. So he had quite an influence on our decision to come to Brooks. And so we came in 2010.
Wow. And you haven't looked back.
No. So, and at that time, I was I don't know if told is the right word, but essentially he said, how about a geriatric residency program? And I remember thinking, like, what is that? And I can't even believe that now,
Yeah. So he asked or told you that. So you got your GCS originally in 2007, correct?
That's right.
So you were, kind of an outpatient ortho, and you were teaching a little bit. Why did you get your GCS? Kind of what happened, or what, how'd your perspective change? You said, I want to get this specialty certification.
Well, it turns out that the USF clinic was very much a place where individuals came because they had difficult diagnoses or health conditions. They had physical therapy in the past and it didn't work for them. And so I really didn't see orthopedic patients. I was really I hate to say neuro even also, but it was a very important, as I look back on it, a very important case mix. It helped me have quite a bit of experience, I think, with very complex patients. And so somewhere along the way, there was a movement disorder specialist who had contacted the clinic and said, I really want to send my Parkinson's patients there. Can you identify a therapist who is willing to see my patients? And of course, the answer was yes. Go ahead, please. And so I kind of was the one who was, again, voluntold, I don't know, but it was the best thing, I think, that helped me realize what value we have as PTs. So here I was working with people in two ways. One was helping them in kind of compensate for whatever losses they may be experiencing, but another was working with a disease process where, evidence is starting to emerge at that time where, hey, exercise might be able to curb the progression here. So that was pretty cool. So that is really what lit the fire under me about older adults, and specifically older adults with Parkinson's disease. And it's somewhere in that journey, I guess, I made a decision towards geriatrics and away from a neuro specialization. But I really can't. I can't really articulate when that was, or
Yeah. Yeah. So how did that change you, like in the clinic? What tangible differences did you notice after you got that GCS behind your name? And this is a selfish question because I'm planning on sitting for it in March, and I'm wanting to. Sometimes I wouldn't say I question signing up for it. Like, man, should I do this? Will I be able to pass it? Is it worth it? So this is more of a selfish question.
Well, I think it's really a good question. And, so I was 5 years out of school when I decided to do this. And I really don't recall doing it because I knew that it would be some amazing platform for learning. Now I absolutely believe that it is. I pursued it because I found that I really enjoyed working with older adults. I wanted to be recognized for it. At that time, residency was really not a common path to specialization. So I didn't have the frame of mind that preparing for it would improve me as a clinician, which I think is amazing to feel like now, when I think back on that. I really wasn't surrounded by people who were like in the know about specialization or residency training or why a PT might want to pursue either one.
Yeah.
I probably thought like, okay, well, I've been working with this group for almost 5 years. My patients get better. I like them. They seem to like me. So let's do this, so,
yeah.
so, so I get my GCS, and now what, so now I think when I think about this, and I am asked this question a lot, but it's more in the context of kind of what you described. There's two paths. There's let me go out there and get some experience and surround myself with people who are of a similar mind as me, and then study for it and take it. And then the other path is residency. So now I think, like, after doing this, I think the answer to why you should pursue specialization or when you do it is really when you're ready, like, to be the learner. You realize that what you have gained is, once you have it. I think what I realized was, all right, now what? What do I need to do to maintain this status? Because now I have a responsibility. I have this label, and I have a responsibility to make sure that I do what it says I can do. And so now I think that I just think that because I think if I had someone say to me earlier, you're going to be perceived as someone who knows what they're doing, make sure you know what you're doing, would have kind of lit a fire under me to say, all right, I want to do this because I want to do what's right for my patient. I want to be the one who helps them when no one else could. Anyway, I think that's kind of a roundabout way of answering that question. But, ultimately I did not pursue it because I thought it would put me on like some path of excellent learning. But I realized that it has. So, if you can't not change and grow by going through the process of specialization. So if you don't want to grow, then don't do it.
Yeah. That's a good point. That's a cool answer too, because that's different from, because I've asked that question a few times, but just to hear almost, you have that sense of professional accountability, that, okay, like I've got this behind my name. I need to be able to perform at this level. It honestly, it reminds me a lot of the RKC. I got this fitness certification. It's Russian kettlebell coach certification. I did the first level, and you have to do these physical tasks, and you're expected to be able to do said tasks if you have RKC behind your name. And so the big one that gets a lot of people is you have to do 100 kettlebell snatches in 5 minutes at an appropriate weight.
As a person who's certified has to be able to do this performance?
Yes. So it's a matter of, it's been the most valuable education certification I've done. It's not, related to PT per se. It's in the fitness world, but I feel like it has that accountability on me, just like you've talked about with the GCS. And I've found that super valuable. But haven't experienced that in kind of the PT world yet. And I'm excited now to think about like the GCS will, I can view that as like that bit of accountability to make sure I step my game up. That's pretty neat to see. So with, so you get your GCS and then you're voluntold, to start this residency program. Do you know Dee Cornetti by chance? She's a home health section president. She lives down, I think, somewhat close to you.
So I know of her, and I have actually met her before, but with a million different other people, probably at CSM.
She voluntells people a lot. She says it too. She's like, I'm going to volunteer you to. She does in a great way, but that made me think of that. So you're starting this residency. Why did you not say no?
Why did I not say no? Well, I'll tell you, I'm definitely of the opinion that if you wait until you're completely 100% comfortable with something before you go ahead and try it, you're late. And so I had a lot of conversations with my husband and with my colleagues at USF, and it was more like okay, and of course with Bob, and it was more like I felt like I was going to have the support that I needed. I am being given this opportunity where one program in the state existed at the time, and that's St. Catherine's, and so I had the opportunity to kind of fill a gap, and I can't even imagine not doing it now, so yes, it definitely crossed my mind, because in the beginning, and it's still kind of set up so that this could happen again, but in the beginning, the first couple years, so my program got accredited initially in 2012. So the curriculum development and things started in 2010, and it was a multidisciplinary residency. So I actually had no PT the first year. I had an OT and 2 speech language pathologists and a nurse. And when I look back on that, it was really helpful in kind of developing the baseline curriculum that was from an interdisciplinary kind of perspective. And so those things were, the fact that it was multidisciplinary was probably a little bit premature. It is structured so that it could be opened up to be multidisciplinary again, but that part was only internal to Brooks. So it's kind of not funded at the moment, but it's certainly like ready to go again. But so anyway, all of that to say that it kind of helped me have a little bit of time to figure out what goes into a residency curriculum that is different than what goes into an entry-level DPT program.
Yeah. That's a good point. So when you were developing this multidisciplinary residency, did you have many interactions with medical residency directors?
Not when it was being developed.
Okay.
No. And so now, yes. much through the efforts of my husband, who had kind of worked out a program with a local family medicine residency that now we have a kind of a curriculum with. I don't really know what to call it. It's not. It's part of the curriculum. So in a nutshell, my residents, who there are 3, and the family medicine residents, of which I think there are 5 or 6 that are interested in geriatrics, they shadow each other. They are paired up and they work on cases. And I mean, the feedback so far, so this is the first year that this has been implemented, and the feedback is like awesome. It's cool. So great where, just like not that long ago, I think it was about a month ago, one of my residents was in clinic with a family medicine physician and a follow-up appointment with older adult female coming back because she still has back pain and the medications she was prescribed weren't working. And the physician kind of was like, oh man, what should we do? Should we get an MRI? Should you, be referred to pain management? And my resident kind of stepped in and said, do you mind if I do a little bit of a physical exam? So the ultimate result was the patient agreeing to go to physical therapy, and the physician saying, oh my gosh, like what else do you do? And it just like was a beautiful beginning of a really nice conversation. So yeah, I mean, I would love for that to happen more and more often. So what's interesting to me about it is I think that there were somewhere along the lines of 30 family medicine residents. And, like less than 10% of them were interested in older adults or kind of specializing in that way. And so hopefully, that this kind of little program maybe changes that a little bit.
Yeah, that's pretty amazing. And I wish we would have more interactions in our graduate programs, but I know there's only so much you can fit in, so many years. But yeah, it is pretty, I definitely think, from the physician perspective of just their limited knowledge of what we do, but then also, the other way around also. So with interacting with more, medical residencies, are there certain traits and characteristics of medical residencies that you feel are helpful in a PT residency?
I don't know yet. I think my answer is probably pretty generic, and that is the fact that the family medicine residency director was willing to kind of like fit this in to a program that doesn't have time for anything else, I think was huge. So there's likely something that exists within the culture of family medicine or maybe just physician residency programs. And when there's recognition that, this deserves some attention. Now, geriatrics in their program is still a 5-week block. And that's it.
Out of a 3-year residency?
I don't know how long exactly their medical residency is. But yeah, so even if it was a year or 2 years, it's still a 5-week block. So my position basically is, okay, if we can do something that really hones in on the application of what we try to promote as prevention of overusing medications and imaging and all of these things. If we can promote interdisciplinary care, then okay, let's do it in this 5-week block. So I'm grateful that there's that opportunity, and so I don't really know what characteristics would be more optimal than others, other than, hey, a willingness to do it.
Right. Yeah, that'll be interesting to see how that relationship unfolds and to see if there's, other specialties. Like I think ER would be huge.
Oh my goodness.
To have collaboration. Yeah, that's cool. We'll have to check back in on that. Or I'll interview your husband. How about that? Get him behind the microphone.
That sounds good.
So, for listeners, just to give them a little background, whenever I interview people, I typically, have them fill out, like, is there anything you want to talk about or, talking points and whatnot? And you replied with some really good ones, but I want you to tell us about the ultimate professional goal. and just kind of how you perceive that and how you use that goal that you create.
Okay, well, I think it could be pretty easy to get lost in the day-to-day shuffle of everything, especially my own experience where I'm married to someone who is as immersed in his field as I am and enjoys it as much as I do. And, we have 2 children. One is 8 and one is 2, and we're busy, and I think that so both of us, I think I can speak for him, kind of serve as a mentor to each other where, there are times when we're like, all right, we need to not talk about physical therapy at all. And there are other times where we'll say, okay, I need to bounce some things off of you. I need your opinion on this or that or whatever. And what has come out of some of those discussions really is don't lose sight of the bigger goal. And so it would be easy to get lost in the shuffle of the day-to-day operations of your life. And so then when something comes down the pike, like, hey, can you contribute to this task force or this article, or can you be the room mom for your kid's grade, or, you can say, yes, I can do that because it's in direct alignment with my professional goal, which really is not different, or my personal goal, which is really not different than, an organization like creating a strategic plan to meet their vision and their mission,
Right.
their mission and their objectives. So I hate to be so stoic. I don't know if that's the word, but it really is a, I guess, business model. I don't know, but it really works very well. I think when sometimes people, and myself included, where I have to teach myself how to say no sometimes, I just cannot do it this week, or this year or whatever. So I think, really forcing yourself to say what, a lot of times we ask each other, I ask my residents, what do you expect to get out of this rotation? What do you expect to get out of this year? What's your 5-year goal? Those are, common questions. But I think what's less common is, sitting down with your significant other or your colleagues and saying, all right, what's our goal for this blah, 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 whatever that is,
Right.
and not losing sight of that.
Yeah. And I think I'm just starting to, I guess, observe this in, some of my colleagues, and I've been out 6 years now, I guess, from PT school. And it's like, when you get out, you typically just say yes, like yes to everything, this opportunity, do this, take this patient, blah, blah, blah. And it's very easy to get, sidetracked in a way from what you perceive as how you want to, live your life or the impact that you want to make. It almost seems like there's this breaking point where, whether it's like a quarter midlife crisis or whatever, but it's like, what am I doing? Like, what's my goal? What's my purpose? And but then the tough part is, since you've said yes for so long, then you get all these opportunities that are really hard to say no to. And I bet you're in that position where you get all these amazing opportunities to speak or teach or contribute to a book or whatever, like the most people would perceive as like, oh, that's awesome. Like, that's such a cool thing, but it may be a bad thing, like given your, ultimate goal. And that's something I just think a lot about now, just having the vision to be able to say no to seemingly good things. Do you,
Well,
do you come across that a lot?
I think that there's some very important wisdom in what you're saying, and that is, in order for anything to be worth it, it has to be hard. It's probably not going to just fall into line, just perfectly, randomly picking the winning lottery ticket. But I think that, I would say earlier in my career, I think I ended up saying yes to things that maybe were uncomfortable, or, it's hard to judge how I would have responded then versus now. But now I think there are still times like if I'm approached with, there's this neat kind of thing that we'd like you to work on. Can you be a part of this? It's easier to decide, yes, I can, because I've already kind of developed in my head and in conversations with my family about what we do when, so I can say to myself, okay, I know that, our family time is during this time or that time. And so I have, X block of time that's mine that I can play with.
Yeah.
And so if I choose to fill that with, writing this book, then okay, that's what I've chosen. So I don't have any business being like, oh man, I didn't get to finish, whatever series this was on Netflix, until later. So I think those types of things you just decide based on, you have to communicate. And that's another thing that my husband and I have recently figured out. And it doesn't seem hard, but it was like, oh man, what took us so long is kind of scheduling family time and scheduling downtime and scheduling work time, right down to, hey, I'm answering emails during this time or that time. And I think to some people that seems ridiculous. And I think to some people that seems like, well, yeah, that's how you do it. And so even though in the beginning for us, it was like, oh my gosh, we have to schedule when to hang out. It was really important to do that, because when you were getting bogged down and things were getting stressful, you're like, oh man, but we have date night coming up, or we're going to the zoo, or whatever it is, so.
Yeah. That, especially with, with that phase of life too, I think probably 4 years ago, I'd be like, man, they're pretty uptight. But now a lot of my friends, are in kind of that life stage that you're in. It's like, yeah, you almost have to do that to, just to continue to be effective and productive and, do the things that you want
and happy
to do. Yeah, exactly. Exactly.
And, my husband and I, we talk about a lot, like, what did we do on a Saturday morning before? Like, why did we have no time? What was wrong with us? Why were we stressed? Why were we stressed out before? What, we had it made, so anyway, it's kind of funny how things get put in perspective.
Yeah. And especially a lot of the younger people listening to this, I really want you to, to hear, this part of the conversation, especially if you don't have friends with kids. It reminds me, I know we may be going off topic, but I can't always think of this. I went for a run with my buddy. He has like a 2, 4, and 6. So they're like 2 years apart, all of them. His life is just a freaking madhouse right now. And my wife and his wife were going to meet us up at this, farmer's market. And we were running up to it. They were going to drive, and we got there before then. And I went and got him a cup of coffee, and we sat on the park bench, and he's sitting there with his cup of coffee. And I look over at him, and the guy's got his eyes closed, and I just see he doesn't say it out loud, but I see his lips say, "Thank you, Lord." And I was like, "You all right over there?" And he goes, "This is the first time I've had a hot cup of coffee in silence in probably over 6 years." At that moment, I was like, "Oh my gosh!" Like, so yeah,
that is so great. And I completely and you wouldn't want it any other way,
right?
I'm sure he wouldn't want it any other way. But then when you're in the moment, it can get a little nuts. And so, when you're trying to balance everything else, I think, to get back on topic.
Sorry.
No, that's quite all right. In fact, I had this conversation not that long ago with Joe, where it was kind of like, man, I'm frustrated at, certain things that exist within our healthcare system. And, he's trying to advocate for somebody in a skilled nursing setting, and he's met with, kind of barrier after barrier, and he's mad about it. We're not mad, but just like frustrated. Right. And so I think that, in that context, it's like, if your ultimate goal is to work to change the system, you will have credibility because you work in the system, you will have experience trying to work within the constraints that currently exist, and you will have ideas for how to change those things, and view it like that, where we have chosen to be in this profession, and what comes along with that is Medicare.
Yeah.
And it's difficult and complex and not a simple fix for every older adult in every setting across the world, across the United States. And so anyway, I think in kind of the same message was in that context where, what's the bigger goal that you're trying to work towards so that you don't get so frustrated with some of the day-to-day barriers.
Yeah. And now a quick break to tell you about our sponsor. This episode of the Senior Rehab Podcast is sponsored by Health IQ. I mentioned before that Health IQ is a special rate life insurance company for health-conscious people like you and me. They have a unique mortality model on health-conscious people that allows them to secure lower rates based on actual data. You can think of it like good driver savings on auto insurance. They also have a unique underwriting process where instead of using common measurements like BMI, they use waist-to-hip ratios, cholesterol calculations, and much more to demonstrate a more accurate view of someone's health. So if you're in the market for life insurance to protect your family and have a little bit of peace of mind, I highly encourage you to go to healthiq.com/SRP to get your free quote and help support the show. Thanks. So another thing that you do, you mentioned you teach the entry-level geriatric course, North Florida, I believe. So, you work with these residents, you're doing, just a lot of, clinical care, really challenging them, diving into the evidence. And then, you go to this entry-level geriatric course, which is definitely related, but I imagine, you may go into it with a different mindset potentially. What are your main goals in that course, and what do you really try and do with your students, considering where they're at in their education?
Well, they are third year students.
Okay.
And the way the structure is, they're in January they'll start their last clinical rotation. So they're pretty much like finishing up with their didactic stuff this semester. In fact, we're in it right now. So one of the main goals with it, and this is a great example of one of those things that I was approached about doing this, and I'm like, oh my gosh, where am I going to carve out time to do this? And the administration there was wonderful. They were like, okay, we can do whatever format you want. I'm like, can we do a 3-hour class once a week? And they were like, yes. And so anyway, it worked. So I think the main goal, honestly, is to help students recognize their biases about older adults before they graduate. And what I find amazing, so the relevance of them being in their third year, and why I brought that up, is that on the first day of the class, I asked them to, I pass around like 2 index cards, and on one side of the card, I asked them to jot down their first 3 thoughts about older adults, and on the other side, I asked them to complete the following sentence, I will be old when. And then on another card, I'll ask them, like, what do they do? Like, if they thought about a geriatric clinical setting, what would that look like? And I can't remember. The other side of that second card is, how do you feel about working with older adults? And then we spend time in the class kind of reading what they say, and it's really eye-opening. And the feedback I've gotten from that is, oh my gosh, I really didn't know that I was doing that, or trying to define ageism without giving an example that what someone just did was kind of like an ageist comment or something, is really valuable. So, some of the stuff that comes out of just that little exercise is very eye-opening.
I would love to do that at my home health agency. That'd be eye-opening as well. So do you do that at the end of the class? that same exercise?
No, and that's a really good question. No, I only do it in the beginning. It's kind of, I feel like, I don't, I wonder, yeah, no, I haven't ever considered doing it at the end. In addition, I've only done it at the beginning.
They may just tell you what you want to hear at that point because they probably already know what you're about. So you do that exercise, and that really brings things to the surface. Do you have any other advice or tips or anything that's been helpful for you? Because there's a lot of people. I shouldn't say a lot. I mean, there's a good amount of educators that listen to this podcast that are in a similar situation that you're in. Do you have any tips for them?
As far as like what I include in the course?
Well, I guess to achieve your main objective for the students to acknowledge their biases before they graduate.
Well, yeah. So I think that one of the important parts about reading the stuff from the cards out loud. So like, for example, the I will be old when kind of statement finishes with stuff like, like, when I can apply for Medicare, or when I have wrinkles, or, when I can't get up off the floor by myself, or, things like old people are so cute, things that are maybe harmless, but lack depth, and so like hashing that out over time, where there's a lot of discussions that occur in the class. And so, I will try to bring up or ask, why do you think that happened? Or, you had this experience as a student. What do you know now that would have changed how you handled that? So I am lucky in that the program dedicates an entire semester to this course. I know there are a lot of PT programs that don't even have a geriatrics course, or an elective course or something. Yeah. So that alone kind of gives the message that this is important because it's part of our mandatory curriculum, versus this is kind of an elective and you choose between this or peds, right. Or something else you want to specialize in. So, I think, I guess the general advice, or I don't know if it's called advice even, or just to encourage and support students in kind of like forcing their clinical reasoning and surrounding like older adults. And maybe like a good tangible example would be, okay, you have, this intervention plan. Tell me what is in there and why, and is it an opportunity to talk about underdosing, or is it an opportunity for a student to say, well, I've had to adjust how I approach this person, and then force the conversation about why. What did you change? Talk to me about why this is different for this 80-year-old person versus if this person was, why is age a thing? Why does age matter, and does it matter? And, that's could awesome. You come up with a different scenario where you didn't consider the age, and how would it change, that type of thing?
Yeah, man, I'm going to be thinking about those questions tomorrow. You're going to be in my ear. Are you ageist, Dustin? Why'd you do that? That's cool.
Yeah. Though. And, a lot of times we don't even realize it,
Right.
We don't even, I was I was part of a Florida physical therapy meeting, a couple years ago, and there was a gentleman in there giving a presentation of the director's report on his thing. And he apologized. He took his glasses on and off a whole lot, and he was reading between his laptop and the larger screen projection. And after a few minutes of taking on and off his glasses, he apologized. He was like, "Oh, I'm sorry. I wanted to avoid admitting that my eyes are old, and sorry, I need my glasses." And I thought, like, why did he say that? Why didn't he? Like, I thought that he looked, rather distinguished with his glasses on, or like, how come? Yeah. How come that's a thing? Like, what made him feel like he needed to apologize because he had to wear his glasses? So I don't think it's intentional, and I don't even think many of us realize that we do it.
Yeah, it's a big cultural issue. Are
Mm-hmm.
you familiar with Ashton Applewhite by chance? She wrote a book called This Chair Rocks.
Mm-hmm.
Um,
Yes.
yeah, that one got me thinking.
In
Just
fact, I use her little graphic of that. So there's a little section in a PowerPoint that I do for my UNF students on ageism, and it's like
nice.
every year I find like a couple more cards
Yeah.
in the Walgreens, like Hallmark cards or whatever that are, kind of in this category.
Yeah.
And so I bring that up there because, it's kind of like it's just a good example of, okay,
Right.
now here's what we intended it to mean.
Yeah. She's
It
awesome.
wasn't meant to be harmful. It wasn't meant to be, and some of them are very funny, but, it definitely contributes to, I think, the way older adults are viewed in society.
For sure. So, all right, well, let's transition a bit. I want to ask you a few listener questions. There's only 2 people asked the questions, but we have 4 questions. Your buddy Joe asked a few. So we'll start with Troy. Troy Mead, he's a home health PT in North Carolina. He says, are there any new innovations in geriatric care that you wished your average clinician knew about? I know it's tough to define average clinician, but let's just say, the field clinician, home health, or, skilled nursing facility, whatever setting, but that just hasn't, necessarily kept up in the research since they've been out of school for 6 to 8 years. They haven't, done a ton of continuing education, just kind of the bare minimum to make sure their license is, still active. What would you tell that person, or what would you wish they knew about in terms of innovations in geriatric care?
Oh, I'm afraid that my answer is not going to be very satisfactory.
That's okay.
Because I think my answer is that it's not necessarily like a tangible innovation or a tangible thing. In my opinion, it's the way in which we approach our plan of care. So. And I almost said episode of care. So like one example of what I mean is, we traditionally, and so you said Troy is a home health PT. And so one of the things that I just wish that we had that hopefully comes to fruition in a different type of payment system is the idea that, like plans of care don't end, it's episodes of care and, wouldn't it be so cool if we kind of like wrapped it up with your patient where, okay, I'm going to be touching base with you in a month, in 2 months, in 3 months, so that we can reassess your status and find out your physical activity levels and find out any complaints you have or any pains or whatever, and create something that's specific for you. So I think my answer is not satisfactory because it's not readily available. It's more like, can the innovation be like a transition in how we view our plans of care? And so, like I think a good example of this is when, Medicare Part B kind of helped us in this way by changing the 30-day reassessment to reassess every 10 visits.
Yeah.
Where now, oh man, great. I can really kind of apply the same strategy that I would apply to, following up because I want to make sure I don't have cavities, to this kind of, paradigm where I, maybe I front load my visits 2-3 times a week for 2 or 3 weeks, and then I back it off. And then, by the 8th or 9th visit, I'm visiting with the person once or twice every other month. And then all of a sudden our 10 visits has spanned the course of 9 or 10 or 12 months. And doesn't that like align with what the evidence says about fall prevention dosing and cognitive health dosing and, building strength dosing and all of the things that we know we need to do for maintaining physical activity. So, I hate to say that I think it's just a shift. I think the innovation is a shift in how we typically do it now.
Yeah.
And I know like my description is more of an outpatient based kind of idea because of the Medicare B example. But I guess that's what I mean is that the way things currently are need to change in order for something sustainable to happen.
Yeah. Yeah.
So I would just say to those in this, doing the day to day right now, do what you can to advocate for your patient, and where, when that doesn't exist, when that ability to stretch out your plan of care doesn't exist in home health right now, be that advocate where you are making the extra phone call to find out if that person got enrolled in their community exercise program, or, even 2 months after the plan was discharged, call them and find out how they're doing, which you don't get paid for, but,
right.
I think the little things that help transition maybe the bigger picture. So I think that's not going to be a very satisfactory answer.
Well, no, I think it's a mindset shift. Just for us to think very differently about how we care for people. Joe did mention to me about something I guess you've mentioned to him in terms of like an ideal care system for the older adult, something that may be similar to like a YMCA type PT setup for the older adult, but cash based. If that rings a bell, could you elaborate on that? And I guess, would that be like a dream of yours?
Yes. So, and I don't like, this is hopefully doesn't turn into me like rambling about this because I don't know the answers to how something like this would work. But I think what I think about is, couple things. One is, when I turned 40, I got something in the mail that says to me, "Hey, it's time to get your mammogram." And okay, great. So how come? What is it about our system that we can't say, "Hey, 40-year-old or 50-year-old or 60-year-old or person that just had a certain health condition, certain health event, can you check in with your PT now?" Or how about a physical activity assessment, or and obviously our system doesn't pay for that right now, right? So and so I guess the closest thing to that is the Medicare, the first time benefit. When someone enrolls in Medicare, they get a covered kind of wellness checkup, and so so I think that our, right now our health system is set up so an individual has to have some kind of serious diagnosis to like matriculate into a wellness program that would help them achieve a function that's more optimal than where they were achieving when they were institutionalized. And, so we react and we put really excellent, well thought out plans to work for people who've experienced some kind of health hardship. And we might be well intentioned and passionate about that rehab care. But then what happens? Like they go home and it ends, or home health ends, or, outpatient ends. And that's that. And so if they have a support system that can get them to a gym or a YMCA, or that's wonderful. And that's not really this niche that I'm talking about. I'm talking about that group that doesn't have the support system, who never considered being active, who doesn't have the mindset that I can do something to prevent further problems or, improve what I feel or whatever, So I do think that somewhere it has to happen before, this idea of a cash-based, membership-driven, maybe, kind of idea has to be introduced to someone before they become a patient in the system.
Right.
And that's a challenge, that's kind of like getting, that's kind of like finding out the value of a monetary value for fall prevention. Like you don't know, because you don't know how many falls you prevented. So, it's probably a lot. So I think that it's something where if in my ideal world, I would have, I don't know, some kind of clinic that was, and maybe this is ageist or discriminatory on age, where you're only allowed in if you're a certain age, You're only allowed to join if you're a certain age. But the idea would be, look, it's not just exercise, but it's what else do you need? It's social interaction. It's, it's, do you need help being a caregiver? Is it, what other things do you need in your life? And so, I don't think that it's appropriate that we should wait for somebody to have a stroke to find out that AFib might have been the cause, or, to find out that that somebody has osteoporosis after they fractured something, or, just to wait for someone to have a traumatic brain injury before we decide maybe this person should have a fall risk assessment. And that's how we operate right now.
Yeah.
So it's kind of more, theoretical mindset shifts and all of that. And I don't know, I am all for being parts of conversations about how to make those types of things happen. But how it works on a larger scale, I don't know.
Yeah. That is interesting to think about. It makes me think of my local YMCA, actually, because one thing that I have noticed is the proportion of older adults that are there, whether it's like the group classes or working out in the gym. But the Y on my end of town in, little old Lexington, Kentucky, I think it's a pretty good example of like a community center that is reaching, the older adult population in an effective manner. But it's almost become like a gathering place, not just, a gym per se. Actually, I'm going to write that down. I need to go. I'm going to try and interview the director there, because that every time I walk in there, I'm like, man, I'm 31. I'm the youngest guy here. And it's like, consistently that. So I'm going to write that down. Well,
and
cool.
that's really, that's really important, because that's a very specific group of older adults. And there's a whole bunch of other older adults who would say, yes, I'd be willing to do that, but I can't get there. I don't have the transportation. I don't have the money. I don't have whatever it is. And so how do you get there? How do you reach that person? And that's the challenge, I think.
Yeah, that's a good point. All right. Well,
I would love to know what the director of this Y says about that.
Yeah, I wrote a note down. I'm gonna dig into that, because they're not normal from what I've observed, just being in a few different YMCAs. The demographic's definitely different, even though the demographic of the area it serves, there's a lot of young people in that area. So it'll be interesting. I'll let you know. I'll let you know if they have any tactics. So I want to be respectful of your time, but I want to finish up with one of Joe's questions.
Okay.
So I think this will be a good way to wrap up. So what's your advice to the burned out clinician treating older adults who's trying to elevate their practice, but are constantly frustrated by mediocrity around them and can't help but feeling hopeless pushing the rock up the hill every day? And I think you could say frustrated by mediocrity around them, or frustrated by, the kind of the system that we find ourselves in. What's your advice to that burned out clinician? Because I think there's a lot of people listening to this right now that may be saying, yeah, that's me.
Well, I think it's important to remember that not that long ago, it was acceptable to document, and I think some people still document like this, but it's becoming less acceptable. So it was okay to basically have a paper chart and a blank sheet that said S, patient reports 4 out of 10 pain, period. O, see flow sheet. A, patient tolerated treatment well. P, continue plan of care. And that was okay. That was never really followed up on, right? So there are clinicians out there who are excellent clinicians who became excellent clinicians in that environment. They have experience with like hundreds and thousands of patients. They say, I know this works because I've seen it work, but they never had to justify it before. And now they have to. And so I think it's important to remember that there are many experienced clinicians out there who are faced with the challenge of making that shift on the job, where they weren't taught like this. They weren't taught to like, they didn't have autonomy. You know, really, when you really go back, and I don't want to be ignorant by saying like putting a date on it, but you know, decades ago when like PTs were technicians really, like, and following orders. And I think in some ways we still do that. And that doesn't match anymore with a payment system that's saying, hey, we're going to pay based on value, not volume, you know?
Right.
So I think it's important to remember that shift is trying to happen. And so if you were educated in the last decade, you were educated with the idea that an outcome measure is a normal part of your process, a normal part of your examination and your evaluation and your plan of care. And I think that's not always been the case, you know. You know, I have another confession I can make, I guess, that was kind of similar to the awful, you know, blunder I made towards the patient that had macular degeneration. And that is, when I was a very new grad, I administered the Berg as a self-report measure. like
Awesome. That's a good idea. I'm gonna try that one tomorrow.
And I got halfway through it. I got to the, you know, turn around in a circle.
Yeah.
And I realized like, oh, you know, so I'm sitting there and like, so if you had to turn around all the way,
would it take you more than 4 seconds or less than 4 seconds?
And I, you know, I think that's kind of silly, but it really demonstrates that, you know, and so I graduated in 2003. And so even then, while my program was excellent at saying, yeah, we need to be doing these, it still wasn't ingrained in my practice. I didn't see my CIs using outcome measures. You know, and so I got to my real job and I was like, ooh, go me, I'm going to use an outcome measure. And I had no idea what I was doing. You know, and I can certainly tell you, I didn't know what the NCID was for the person I was using it for, right, or anything about cutoff score, you know? So I guess to circle back to the question, and that is recognize that there are many clinicians that are trying to adjust to the environment that we are in. And so if you, what I think a clinician can do is kind of ask questions and say, hey, I was wondering why you were doing that. And can you like show me what you were doing, and use that as a way to say, oh, hey, you know, I went to this course over the weekend, or I read this article and, you know, maybe you'll find it interesting, or, you know, let's have a little journal club once a month or something like that, to really kind of make it normal to have these conversations about why you're doing what you're doing.
Yeah, man, that's really helpful. The question why is just asking, why are you doing what we're doing? I mean, it seems more often than not we get questioned on why we wrote down a certain thing, or why we didn't, you know, click this box, or, you know, just kind of like crossing our T's and dotting our I's. But to shift the emphasis, well, I guess, you know, you can emphasize this within documentation, but why are you doing what you're doing, and to be able to justify that. But yeah, that's a good question to continue to ask for sure.
Yeah. You know, I think in the context of documentation, I think it's important to remember that you don't really know who the audience is that you're writing for. So you shouldn't try. You shouldn't try to write it so that you'll meet the criteria of the place you work, or, you know, basically you're doing what the patient needs. And if it's important and medically necessary, then you're going to get paid. And if you write down why it's important and medically necessary, you're going to get paid. So, you know, the idea that you have to write a certain way for a Medicare patient and a certain way for a private payer and a certain way for a self-pay is kind of silly, and definitely doesn't meet the bigger goal, the bigger picture of are we providing quality? So there shouldn't be like a, yes, we're providing quality, you know, disclaimer. if it's a certain type of payer. That's
right.
silly.
That's a good point. Well, Jackie Osborne, I appreciate you taking the time on a Tuesday night, which I know you probably had a super long day and put the kids to bed and then rushed over to the computer to hop on this call. But yeah, I appreciate, I know a lot of people will as well, just the perspective and the career that you've had up to this point. I mean, it's pretty wild, just the journey that you and your husband and family have been on. But I know there's some definite encouraging words for a lot of listeners, but then me too, honestly, just to think big picture about things and to focus on that person in front of us and not that big start of care that I have to do on the computer. So if people have questions, what's a good way, if there is a way, to ask you? Are you on Twitter? I know you're new on Facebook, you told me, right? So we'll stay away from that.
I am new on Facebook, and that's okay. Like I did tell my residents, like, if you really want me to know something, please don't use Facebook because I might miss it. And so I am absolutely happy to give my email because that's probably the most direct. But I am also on Twitter, but not as often. So I'm trying to find that balance of like, how much do I need to look at it? And so I think email is a wonderful way to get in touch with me, and I'm happy to give out my email.
Okay. I'll just put that in the show notes for listeners. So there will be a link in the show notes to your email. I'll go ahead and link your Twitter account as well. And so just thank you for your time. Thank your husband as well for letting me steal you for the evening.
Well, I just want to turn it around and thank you for your efforts with the podcast. And I think this is obviously an excellent platform to start conversations and continue conversations. And, this is something that wasn't a part of anything just a few short years ago. So, so thank you for what you do.
Hit me. Thank you for listening to the Senior Rehab Podcast. If you only listen to these podcast episodes, you are missing out on 90% of the Senior Rehab Project. Hop on over to seniorrehabproject.com where you can join the movement that's advancing care for older adults. You can join for free or become a part of the Game Changers where you can get some free gear and access to our monthly meetup. Just go to seniorrehabproject.com. I appreciate y'all, and I'll talk with you soon. But in the meantime, do not forget to stay funky.